we're really excited about that, right? We really like talking about perianal fistulas, and so we'll probably won't last the hour, but we'll talk a little bit about it. And for the applicants, just so you know, the way we kind of do at least a lot of my talks, and the way we're kind of moving in how we give these talks, is that beforehand I make a little video for the residents. This is just a screenshot from the video, and it's kind of if you watch Khan Academy at all, it's kind of Khan Academy style chalkboard talk that kind of goes through the big picture of what I'd like the residents to know. And we don't have these videos last, I don't have them last any more longer than about 12 or 13 minutes, so you can watch it when you're having dinner, just a quick video. And then so when they come to the lecture, they're kind of primed with the information they need to know, and the idea is that they would get more out of it in that context. So hopefully they've had a chance to look at it, and we'll go through the content in the next few minutes. So we got some objectives, right? By the end of this hour, I want you guys to know a few things. On a bigger picture, I mean, this is even for the applicants. If I'm kind of successful with what I'm attempting to do today, all of you are going to go to the reading room after this and have an approach to interpreting MRIs for perianal fistulas. More specifically, I'd like you to focus on the anatomy. If you understand the anatomy of this region, that's half the battle, right? They don't teach that stuff really well in med school, and a lot of the times you learn it while you're in the reading room itself. So in terms of anatomy, if you're able to identify the internal and external sphincters, that would be one success. There's a whole bunch of different types of perianal fistulas that we're going to go through. If you're able to identify perhaps the two most common, you can recite that at the end of this talk. I think that would be a good thing to achieve. And finally, we're going to go through a systematic approach to how to interpret these studies. And by that I mean we're going to have a reporting checklist. So if you have an idea of how to kind of go through these cases with that reporting checklist, that would be amazing as well. So we'll start off with anatomy. This is a coronal schematic of our picture of the lower gastrointestinal tract. We're at the level of the anus here. This is the sagittal image, just to orient everybody here. This is the bladder, that's the uterus, and that's the large bowel. That's the pubic symphysis, one of our bones, and the coccyx as it comes around over here. As it turns out, anatomically speaking, the anal canal really is at the, if you work backwards, at the level, it reaches upwards to the level of the dentate line. So what's the dentate line? You've kind of probably come across that at some point. The dentate line is that area where kind of the squamous epithelium that is contiguous with the skin goes upwards and transitions to the columnar epithelium that is more often seen throughout the rest of the GI tract. And there's no line per se, and it's certainly not colored in blue, but there's going to be an area where this transition takes place. There's a whole bunch of glands in that location. That becomes important when we talk about perianal fistulas. Now that's from an anatomic perspective. From a surgical perspective, from an imaging perspective, we define it a little bit differently. So there's this nice muscle called the puborectalis, and it goes from the pubic symphysis, goes all the way back and wraps around a portion of the bowel and then actually slings back up again. And it's at this posterior impression of the puborectalis that I want you to pay attention. Everything above it will be rectum and the remainder of the large bowel, and everything below it will be the anus. And the anus ranges in size anywhere from 3.5 to 5 centimeters based on the surgical and imaging anal canal. So that's kind of the definition we're going to be using for this talk. This is what it looks like on imaging. I'm sure all of you have seen MRs, and if you haven't, we'll orient you again. This is what we call a T2 weighted image. And very simply put, in T2 weighted imaging, anything that contains fluid is bright. So our bladder contains fluid, so this is our bladder, it's going to be bright. This is the pubic symphysis, that's the large bowel, that's a really big uterus with lots of fibroids, and that's the coccyx. And you're not going to see the puborectalis in this plane because it's going to go like this, but you're going to see its posterior impressions. It's going to be this area over here, just like that red portion. And so everything above this kind of hypothetical line we can draw, the puborectalis over here, is going to be large bowel, and everything below it is going to be the anus. So we look at our sagittal images to help us with that. So I'm sure you guys have thought about this at some point in your careers. What is the function of the anus? I never really thought about this, but I think it's important to think about it because it makes things a little bit easier. And the way I look at it, it's nothing but a big sphincter. Right? It's what allows us to decide we want to go to the bathroom or we want to keep it in for a little bit longer till the lecture's over. Right? So it essentially acts as a sphincter. And this is an axial image here. That's going to be a portion of the anus. That's the vagina. That's the urethra in this particular patient. And it's made up as a sphincter of two different muscles. All right? So these are the things that I want you to know, these muscles. The first one is the internal sphincter. Now, the internal sphincter is easy in the sense that it's just a continuation of the circular muscle of the rectal wall. So when I'm going to show you images, when you see the rectum, when you see the anus, essentially, whatever you see there is going to be composed for practical purposes of the internal sphincter. On MRI, it's going to be very difficult to differentiate the anus itself from the internal sphincter. So we'll consider that all the internal sphincter. So that's an axial image. Let's see what it looks like on coronal imaging. So this is kind of mirrors this a little bit, but this is another T2 weighted images. And your anus is going to go all the way from about here to here, okay? And this kind of grayish looking structure here is going to be your anus. And for our practical purposes, the entire breadth from here to here, we can consider that the internal sphincter. Not all of it in reality is the internal sphincter, but you cannot differentiate it from the other different layers of the anus. On axial imaging, so kind of reflecting this diagram over here, this is going to be your anus. And again, for practical purposes, we're going to consider this whole thing as our internal sphincter. Okay? Well, that's not good enough. We need two sphincters to help us. And so that's the internal sphincter. And then you have an external sphincter. That its name implies is external to the anus, right? So this is the external sphincter over here. It's a voluntary muscle. And as you go upwards, its superior aspect of it is contiguous with other muscles in the pelvic floor, namely the puborectalis muscle. And I say that because it can sometimes be very difficult to differentiate those muscles on imaging. But for your purposes, when you have a muscle that's kind of paralleling the wall of the anus on the coronal plane like this, all that's going to be your external sphincter. And it comes around, it's the right over here and kind of does a boomerang and wraps around the anus over here. So what does that look like on imaging? So again, our internal sphincter is going to be essentially the wall of the anus. We can't differentiate it. The external sphincter is going to be this little dark signal that's just outside of it, over here and over here. And as you go superiorly, at some point, it's going to be contiguous with the puborectalis muscle, which is going to be a muscle that comes across over here and over here. Some axial images for you. Again, we know what the internal sphincter is. We're all experts at that now. I'm talking about the external sphincter. It's outside of it, this dark band that's wrapping around the anus. And as you go kind of from more superior to inferior, sometimes it takes on a more V-shaped configuration as you just follow it down. So we got an internal sphincter, we have an external sphincter, and we have a space in between it, aptly named the intersphincteric space. All right, so that's going to be this stuff over here in yellow. And for practical purposes, all it contains is fat. Maybe a few vessels, maybe a few tiny nodes here and there, but really just contains fat. And that's an important space to know about. This is what it looks like on the axial images. It's just going to be this yellow space in between the internal and external sphincters. Right over here, highlighted in blue. So again, if we look at a coronal image, we know what the internal sphincter is. We know what the external sphincter is. And this, at the tip of my arrow, this really kind of bright appearing signal between the two is going to be fat within the intersphincteric space. All right? On axial images, again, internal sphincters, this whole thing over here. External sphincter is the dark signal outside of it. And in between is the intersphincteric space, which contains fat, again, has bright signal. And so if you know those three things, you're well ahead of the game. Now I'll make things a little bit more confusing. I know from my experience with the residents, they love these muscles when I question them about it. The levator musculature, the most impossible muscles in my mind to kind of trace and talk about. But they're important to know about. And as you go upwards, you have the external sphincter. Somewhere it's going to join and become the puborectalis. And as you go even more cephalate and more upwards, that's going to be a portion of the levator plate up here and up here. So that really convex, bulging outwards muscles that go across over here. And you can see it over here as well on this coronal diagram. And it's made up of a bunch of muscles which are almost contiguous with one another and may be difficult to differentiate. And I don't need you guys to differentiate those muscles. You may need to know those muscles for multiple choice exams, and so you'll memorize it when you need to know it, but understand that there's something called a levator plate that consists of these muscles, and that is seen when you go more cephalid from the external sphincter to the puborectalis, and now you get into the levator musculature up here. Okay. Oh, you have a question?
So the external sphincter is just that levator plate is just a continuation of the external sphincter, is what you're saying?
The external sphincter is a continuation of the puborectalis, and the puborectalis, along with the other two muscles, make up the levator plate. They're a group of muscles. So in some sense, it may all be one continuation, but it's actually contiguous with the puborectalis. So we have the two sphincters down, we have the space in between down, and this is also kind of important to know if you want to just name things appropriately. So we talked about our puborectalis muscle coming from the pubic symphysis and its posterior impression over there. So let's draw a line over there. All right, that line goes all the way back into the fat, and that's the gluteal region over there. Anything above it is going to be the ischiorectal fossa. All right, so if you have anything happening in this space, it's going to be the ischiorectal fossa. And anything below it is going to be the ischioanal fossa. Well, that makes sense. And I find it very difficult, I'll be honest, on axial images as I scroll through to tell you where the ischiorectal fossa is or the ischioanal fossa is. So I cheat. I don't need to call it cheating, but look at all the images that you get. Look at your sagittals. And just pinpoint, are you above or below that puborectalis muscle so you can name things appropriately. Ultimately, it probably doesn't really matter what you name it in your reports, but for our purposes, we want to be as accurate as possible. So just to kind of appreciate these are, I think radiology is really difficult to view in static images. And, you don't have the benefit of scrolling through things right now, but I'll scroll for you. This is a coronal image. This is a sagittal image, and we'll go through the same things again. As you go from front over here to back. This is the bladder. That's the prostate gland. This is a coronal image. Here we get to the anus. That's going to be the internal sphincter, this stuff here. The external sphincter over here. The intersphincteric space in between. At some point, this is going to go cephalid and continue as the puborectalis muscle. And as it goes even more cephalid, all that's going to be the levator plate over there. All right, so just look at that. That's a normal case. And on the axial, similarly, nice rectum, intersphincteric space, external sphincter. As you go higher up, at some point, this external sphincter is going to go and continue as the puborectalis muscle. And it's very difficult to delineate the rest of the levator plate on axial images. That sound reasonable, guys? Pretty much experts on anatomy now. That's all you need to know. Just know your internal sphincters, know the space in between, and know that there's something called a levator plate that goes higher up. So let's talk about MR evaluation. MR is really the standard of care to evaluate these things. And I see Dr. Burrell sitting there, I'm sure. Occasionally you may get cases where you have to inject these fistulas under fluoroscopy and see them. But I haven't had to do one, I don't think, in a long time in my training. And nowadays we get asked to evaluate this on MR a lot. And, and it's really because MR has amazing soft tissue resolution. You can really see these things very well. And I'll tell you, at least for the residents, this is becoming a very popular thing that our ER physicians order when patients come into the ER. So these are immersion studies. So we've been, woken up at 2 o'clock, 3 o'clock in the morning to read these studies. So this is important to be familiar and know how to interpret these. So who gets perianal fistula? A whole bunch of people can get them. But the idea here is that there is some degree of chronic or ongoing infection or inflammation for whatever reason. It could be traumatic, some infection as a result of that, radiation for other tumors, for example. Or tumor itself can give you these fistulas. Sometimes we're not really sure why it happens. But in our patient population, the vast majority of people who get it are those with inflammatory bowel disease. Crohn's disease, we had a case yesterday with ulcerative colitis. And why does it happen? Well, the ongoing theory is something called the cryptoglandular hypothesis, which is really cool to say. And that explains some of these reasons why the perianal fistulas happen. So back to our diagram, we're all familiar with this now. And we'll introduce, it doesn't have to happen at the dentate line, but because you have a lot of anal glands concentrated in that area, that for whatever reason you have infection, you have inflammation, these anal glands, which should normally, this is in blue, open up and drain into the bowel, they get blocked up, right? So that opening gets blocked up. So now you have this, this gland that can't drain properly, and there's stasis, and that can get infected. And one thing you'll find in the human body is that whenever something's under a little bit of pressure, it finds a way to decompress. It doesn't like to be in that sort of pressure. And so we can see another anal gland in the axial plane over here, and it is how that gland decompresses into the adjacent areas of the anus that determines the types of fistulas you get, the types of abscesses you get. And so what do we do for our technique? All right, we do a whole bunch of sequences. Our key sequences, in my opinion, are 3. Right? We've talked about this T2 weighted imaging. That's what the I stands for there. Sequence in which fluid is bright. And I find that very useful to look at anatomy. So we've shown a whole bunch. All the images we've shown so far are these T2 weighted non-fat SAT images. I'll explain what that is in a second. So that's very good. Scroll up and down. And we do them in different planes, in the axial plane, in the coronal plane. Figure out your anatomy. Then we apply something called a fat SAT band, and what that basically does is makes all this fat over here go very dark. You see all that fat is very dark. And we tweak the sequence a little bit, and this sequence is even better at the T2 weighted images to look for fluid. All right, so I use the T2 without fat saturation to look for anatomy, and I use this sequence to really look at the tracts. Is there fluid in it? High T2 signal. Is there an abscess? Abscess contains pus and fluid. That also will have high T2 signal. So I use these together. And the last sequence that I like to use is what we call a T1 weighted sequence. On T1 weighted sequences, fluid is dark. All right, T2 it's bright, T1 it's dark. I use a T1 weighted sequence. We give a little bit of contrast. And we have this C1 post-contrast sequence. It's very good to delineate the borders of the fistula. Okay, and figure out if there's an abscess, if it's a rim-enhancing collection. So these 3 sequences, I think, are the most important sequences that I look at when we do these fistulas. And they basically do a combination of these types of sequences when we evaluate these studies. Back to our diagram again, a little bit of a close-up. Some of you may have done MRI rotations. Some of you will do MRI rotations. And the idea of this getting an axial image or a coronal image, if we look at this in sagittal plane, if we were to get a true axial through this, a regular axial or a regular coronal, it would be in this plane, right? And a true axial, how we would normally get it, would be in this plane. The problem of that is that you could be kind of missing some of the fistulous tracts itself. You really want to go axial and coronal with respect to the plane of the anus, which in fact is kind of in this plane over here. So we want to make sure technologists don't do that. And they're very good at not doing that, but when we have to monitor these studies, we want to make sure that they do it properly. So we don't like that. Instead, our coronals will be as such, angled a little bit, so we get into the plane of the anus over there, and angle this way in order to get proper axials. All right, so that's how we do our T2 weighted sequences in order to get the best anatomy on these cases. So I'm going to talk a little bit now about a reporting checklist. All right, we all know the anatomy now. We know what sequences to look at. Excuse me. I'll touch upon this now, and then we'll go through the types of fistulas, and we'll touch upon this again so you guys can kind of get your head around all these things. So when we talk about anal fistulas, one of the important things to make sure you mention is where the mucosal opening is, so where it's arising from within the anus. And when we look at the anus in our axial images, we pretend it's a little clock. Right? So 12 o'clock is there, and you go clockwise, you get 3 o'clock and 6 o'clock and 9 o'clock. And so, we mentioned that the anal mucosal opening appears to be arising from a certain clock position, 2 o'clock, 5 o'clock, 6:45, something like that. But that's for the opening. The other thing you want to tell your referring physicians, the distance of that opening from the anal verge. Right, the anal verge is really where the anus meets the gluteal, the skin portion over there. So that's this arrow over here. And so if you can, give them an approximation Is it 2 centimeters above it? Is it 3 centimeters above it? Is it 2.5 centimeters above it? It helps them when they go in and try to figure out where these fistulas are. Obviously, we want to talk about the type of fistulas, and as you'll see, at least at Yale, they're seldom just simple fistulas. They tend to be very complex, and they can be challenging, but the key is to try to make it simple for yourself, and just take each individual fistula and just describe it with the same sort of nomenclature, and kind of go through it systematically. Mention if there's an abscess, right? If there's an abscess, then you may need to do an intervention and drain it. Mention if the fistulas and the abscesses, or is there a lot of swelling and edema of adjacent muscles or organs even, is how aggressive really is this infection. And you also want to make sure for a supralevator component. So this is the levator plate, and as you'll see, some of these fistulas can travel upwards and abut this area or go right through it. And the problem with now these fistulas going cephalid and going in this location is that they're starting to enter the pelvis itself. And once you start to enter the pelvis, the chances of that infecting organs and other structures in the pelvis is a little bit more likely, obviously, and chances of those infections being more aggressive is more likely. So that's something that the colorectal surgeons may want to act upon a little bit faster. So we'll go through this at the end as well. All right, so let's start talking about our types of fistulas. Now, some of you may have come across this, some of you may have done research in this, some of you may read about this for fun, and you'll see that there's some classification schemes for fistulas. I'm not going to tell you about them yet, but I'm going to describe what these fistulas are, and if you're able to describe them, you're automatically placing it into one of those classification schemes. So I don't like to remember all these schemes, I just want to be able to describe what I see. And then that way you'll see that it'll fit into one of those classification schemes. The first type of fistula is called a superficial fistula. So here we have an anal gland again, that's infected, that's blocked, and now it needs to escape. So this one decides that it's going to go right through the anal wall itself without really disturbing that internal sphincter. Okay? Now the literature would suggest that it's goes from anywhere from 10 to 20%, 16% I've read in one study. And I haven't really seen a good case of this. I had one case recently, but not many cases at Yale. So I think it's probably a little less common than that number, but that's the number out in the literature. It's certainly not the most common type of fistula. So this is a case we saw recently. So that's what it looks like. This is a T2 weighted image in the coronal plane, and this is a T1 weighted image with fat saturation and with contrast. Right? We said on T2 weighted images, fluid appears bright. So here we have this collection here and a little tract going downwards. And on T1 weighted images, fluid is dark, but as an abscess, its rim will be enhancing. So we have a rim enhancing collection with a tract that goes downwards here. And as it turns out, this didn't really go through the anal wall itself. It was kind of confined to the anus and didn't kind of breach through the anal wall into the intersphincteric space. And so if you look at it on axial imaging as we scroll through it, there's a lot of other fistulas, but you can see this is the abscess at the top, and going downwards continues as a tract completely within the anus itself. So this would be a type of superficial fistula, and you can here see the intersphincteric space that looks clean. On our T1 weighted post-contrast image, we can see a rim-enhancing collection. Again, fluid is dark on T1 weighted images, so we don't expect here to see any signal here. We do see that it's rim-enhancing, and it goes all the way down over here, and again, does not go through into the intersphincteric space. So superficial fistula is very uncommon. If you want to forget about it, you're allowed to forget about it. And I don't want you to forget about this one. All right, so one of our objectives was to go through the two most common types of fistulas, and this is probably the most common type of fistula that you'll see, this intersphincteric fistula. So by the same logic that we've gone through so far, you have a gland that's obstructed, needs to escape. So what's this one going to do? It's going to go right through, go through the anus, go through the internal sphincter, and it's going to go through the intersphincteric space and kind of decompress through that route. It will not cross the external sphincter over here. All right, and it'll go escape and track down to the gluteal region. So this is an example of what it would look like. On static images, I have dynamic images after this. Coronal T2 weighted image, T1 post-contrast image in the same plane. You can see that there's very thin fistula right over here. Okay? If you compare it to the other side, you don't quite see anything that looks like this on the other side. And when you give contrast, the rim of that collection enhances, and the internal portion of it, like right over here, shows no enhancement. So this is a very small fluid-filled intersphincteric fistula. Now, if I were to describe it, I could figure out where the clock opening is on the axial images, I think on the next slide, and I can discuss where the distance from the anal verge is probably from here to here. So that would be one way to describe this fistula. It's right over there. So again, we can look at it now on the axial images post-contrast sequence. This is an intersphincteric fistula. It's arising, in my opinion, from about the 10 o'clock position. This is the external sphincter. That's the internal sphincter. This is the intersphincteric fat. And as you scroll downwards, it is confined to the intersphincteric space. And so it's an intersphincteric fistula. So if I were to describe this, I would say there is a intersphincteric fistula containing a little bit of fluid. The tract contains a little bit of fluid. It arises from the 10 o'clock position at approximately this many centimeters from the anal verge. And that's a very succinct way to describe this, this fistula. And then I would say, I don't see an abscess associated with it as well. And just to kind of hammer this point home, this is a T2 weighted images with fat sat. We can see once again a fistula with fluid in it. This is the same fistula that's tracking all the way downwards to the gluteal cleft over here. Now, if life were like that with fistulas, I'd be very happy. I'd be happy to read these studies. But the problem is that invariably these fistulas come and they can be simple like this. But a lot of times, and particularly through the emergency room, they tend to be really complex. All right, they come down here, then they decide to have a secondary tract going upwards or associated with an abscess. They can have this horseshoe-shaped kind of abscess as well, and so you want to make sure that you look for all these things. And I'm not going to go through, well, this case actually shows you what an intersphincteric fistula with an abscess would look like. Again, we have a fistula that arises, looks like from the 3 o'clock position. Here to here, I can measure the distance from the anal verge. So it's an intersphincteric fistula from the 3 o'clock position, goes downwards, and terminates in this rim-enhancing collection on these T1 weighted images. So that's a big abscess over there. So the colorectal surgeons will need to take care of that. And this is just a static image showing the tract that this goes downwards and terminates in this abscess. In this case we had from the ER a few months ago, just shows you how complex these cases can be. Here we have this kind of a horseshoe-shaped collection. It's actually pretty much circumferential around the anus, and there's tracts that are going downwards in the intersphincteric space, terminating in an abscess down here. There's another abscess up here. There's tracts going upwards there. So, this guy's in a lot of trouble. But, again, you just kind of go through each mucosal opening, tell them where it's opening from, distance from the anal verge, is it associated with an abscess or not. Do it systematically, and you'll get through the case. So I want you to know about intersphincteric fistulas. Then I want you to know about transsphincteric fistulas, because you're going to see these ones as well. These ones, as you can imagine, we have an anal gland that's blocked. It doesn't decompress through the anus. It doesn't decompress through the intersphincteric space. But this one goes through the external sphincter as well and decompresses downwards to that ischio-anal fat pad, and just like that. I'll show you another example of that. This is a T2 weighted image with fat saturation. And we can see a tract that's coming from the 6 o'clock position. This is the internal sphincter. That's the external sphincter. It goes through both and goes downwards, terminating in the region of the left gluteal region. And with contrast, you can see that this tract rim enhances. Sometimes the rim enhancement may be difficult to appreciate because it's really, really small, but you got to window it, you got to zoom up. But this is a fluid-filled transsphincteric fistula arising from the 6 o'clock position. And this is the static image showing how it's arising from like the 6 o'clock position and going through both the internal and external sphincters out to the ischio-anal fat pad. And they can be kind of subtle at times as well. So here we have another case of a gentleman with a perianal fistula, and this tract is really, really small. It may contain like a tiny amount of fluid, and you can see it coming from here. So I'd maybe say it's a 3 o'clock position. Certainly crosses the internal sphincter, crosses the external sphincter as well, which would be over here. And this is the tract, so it's gone right through it and goes all the way downwards to the left gluteal cleft. And you can see that tract a little bit better, I think, with the post-contrast imaging right over there, if you follow it, coming out from the 3 o'clock position and extending downwards right over there. And this is what it looks like on the static image. Just like, kind of looks like the diagram that I drew going all the way downward over here. And again, if all I had was simple appearing intersphincteric fistulas and simple appearing transsphincteric fistulas, my life would be really amazing. But this always makes it more interesting that all these transsphincteric fistulas can have multiple additional tracts and multiple abscesses, and so you want to be able to look for them and comment on them. So here we have a case, really complex fistula. So it comes across again from the 6 o'clock position, crosses the internal sphincter. This is the external sphincter coming across. So it crosses both. So we've deemed it to be a transsphincteric fistula. But as it goes downwards, it goes into this area, and that area goes into this area, and this area, and this area, and this one, and this one. So multiple secondary tracts and abscesses in that location. One of these tracts goes anteriorly. So a real mess over there. And you know, for this one, I would just say that there's a transsphincteric fistula arises from the 6 o'clock position, however many centimeters from the anal verge. It courses downwards into the right gluteal region where it's associated with multiple secondary tracts and a couple of abscesses measuring this by this by this and this by this by this. So again, in one line, you can kind of describe what you're seeing. So those are the two things that you'll see the most common, intersphincteric and transsphincteric, and we know how to diagnose them. I'll talk about this supra-sphincteric fistula. And in this, you have a mucosal gland that's blocked, and instead of decompressing caudally or through the external sphincter at the same level, this one's actually going to travel upwards for whatever reason and exit through the levator plate, or at least abut the levator plate. And that's why you need to know about the levator musculature. And so again, we don't see too many of these that common. This was one that we saw where you have a fistula from right, I think 6 o'clock, 7 o'clock position. One tract goes downwards, it's an intersphincteric tract. Let's follow the other tract, going upwards, and up and up and up and up like this. And this is the levator plate that's coming in over here, and going all the way and abutting it. And I don't think this one went right through it, so I don't know if I can technically call it, supra-sphincteric fistula, but certainly you would say that this is an intersphincteric fistula with a tract that goes upwards and abuts the levator plate. And that's fairly important, as I said, because once it's at that level, the chances of it infecting the remaining organs and structures in the pelvis is a lot more likely. So they need to intervene on that sooner than later. This is a static image showing this rim-enhancing tract going all the way upwards to the levator musculature. And on this image shows that there's a little bit of fluid in it going all the way upwards. And finally, one of the least common is this extra-sphincteric fistula. So as its name implies, this does not arise in the anus, right? Because the anus is a sphincter. This is extra-sphincteric, so it's outside of the anus. And very uncommon. And the idea here is that this arises for whatever reason, perhaps from the rectum, and exits through the levator plate, something like that. And I don't have actually an example of this. We checked through our database of cases. I couldn't really find one, at least one that was described over here so far. And the only issue with this one is that the idea of this cryptoglandular hypothesis, where we have an anal gland that gets obstructed and decompresses through the anatomy of the anus, doesn't really apply to this. There may be other glands that get obstructed and result in these extrasphincteric fistula, but certainly the cryptoglandular hypothesis does not apply to these fistulas. But it's important to know about them in case you come across it and to indicate that this, in fact, does not arise from the anus itself, but higher up in the rectum and large bowel. Now, one of the things that you'll come across in our reports when you look at these cases is this concept of granulation tissue or phlegmonous collection. So for me, an abscess is a rim-enhancing, kind of loculated collection. It's a discrete collection that contains fluid inside of it, such that if I put a needle, I can suck out some fluid, suck out some pus from it. A phlegmon is something that may rim enhance, but inside of it, I don't see fluid. I see kind of more granulation and maybe a very tenacious kind of material that's very difficult to kind of suck out if I put a needle in it. And so, it's very difficult. It's important to mention that to the surgeons because they need to know if they're going to go in there, they're probably going to have a really tough time getting anything out of it. And some of these tracts, as we've seen, a lot of them will contain fluid, so they'll have bright T2 signal, and they'll be rim enhancing. But some of them won't contain fluid. They'll be the remnants of prior tracts that have since closed up. And those ones will not have any bright T2 signal. So if you look at this, I don't see any fluid signal here. I do see bright signal, but it's certainly not as bright as I would expect, fluid in, say, the bladder to be. Right? So there's no discrete fluid in this, and there's no tract that I can see that's rim enhancing. So if I see something like this, let's say, there's a perianal fistula at this mucosal opening, at this distance from the anal verge, but it doesn't contain fluid. It contains more granulation material. And that's important for them to know about because they can't really do much if it doesn't contain fluid. And one of the last things I'll mention in terms of looking at these is that sometimes one of the treatments for these perianal fistulas is they place the seton, which is like a little suture through that fistula tract. And the idea, as I understand, is that you put the suture in and it causes some pressure necrosis inside the tract, and the body then kind of regenerates tissue in that area to kind of fill up the tract that had fluid in it. And so you'll see that sometimes when we follow these patients, and it'll look like this curvilinear, very, very dark or hypointense structure that is within the mucosal opening of the anus and goes throughout that tract in the fistula. So don't be alarmed when you see one of those things or just a seton. So we're experts at fistulas. We know the anatomy. We know how to describe them. We have a checklist. And these were the two classification schemes that I think you'll come across if you do a little bit more reading about this. There's the Parks classification scheme, which is a surgical classification scheme, and in some sense it's very similar to what I went through in terms of the intersphincteric and transsphincteric fistulas. And then St. James classification scheme, which is actually a radiology classification scheme. And in that one, it's similar, except they break down the fistulas into whether they're simple, with just one tract, or intersphincteric fistulas with abscesses or secondary tracts, and a transsphincteric fistula or a transsphincteric fistula with abscess or a secondary tract. And the fifth one's a supralevator one, and extra-sphincteric also kind of goes in there. So you can sit and you can memorize this, or you can learn how to just describe these. Because if you describe them properly, you're automatically putting them into one of these classification schemes. And at least our surgeons don't require us to put it in the report, so I don't commit this to memory. This is just to show you that if you, wherever you go and whatever you end up doing, you may come across this scheme, and so now at least you've heard of it. So we'll go back to a reporting checklist now that we know the anatomy, now that we know what these fistulas look like, we know the classification schemes. Remember, we talk about where it's opening from, use the clock. Remember the distance from the anal verge. You can use sagittal or coronal images to determine that. Talk about the type of fistula. Talk about if there are multiple components, if there are abscesses associated with it. Is there edema and swelling of the muscles, bones? A lot of these fistulas can go and infect the bones, and there could be osteomyelitis. You need to be able to mention that to your colorectal surgeons. Check if there's any components that go above the levator plate, abut the levator plate, or go through it, as that can have clinical consequences. And again, we've been acquainted with this classification scheme. We've gone through anatomy and MR evaluation. Let's go back to our objectives. Everyone knows now what the internal and external sphincters look like. Everyone knows the two most common types of perianal fistulas, intersphincteric and transsphincteric. And we're all familiar with a reporting checklist in order for us to tackle these cases. And that's perianal fistulas. Thank you.